Good day, everyone. You're welcome to my YouTube channel, Everything Medical. On this video, we shall be appreciating a compassionate bony structure which is called the femur. The femur is the longest bone in the human body. That makes it to be distinguished from other bony structures. If you are coming across to my channel at the first time, remember to subscribe, like, comment, and also share our video so that other students will see it and benefit from it. Now let's proceed. Here on my hand is the femur bone. The femur is the long bone of the thigh. It is known as the longest bone in the body. It is homologous to the bone of the arm, which is called the humerus, right? It is a long bone because it has a central shaft. From this point to here is the shaft. It also has both extremities, the upper proximal end and the lower distal end. That makes it a long bone. Now, let's quickly look at the features of the upper proximal end, right? The first is the rounded, smooth head. It has the cylindrical neck. It has two bony projection or processes, which is the greater trochanter and the lesser trochanter. It also have two bony ridges, which spans or connect the two trochanters, where we have the intertrochanteric crest, which is here, and also the intertrochanteric line, which is on this region. So those are the features of the upper proximal end. It also has a bony depression, which is called the intertrochanteric fossa on this region. Now let's quickly discuss these features. Let's start from the head. You can see that the head is rounded. The femoral head or the head of the femur is smooth and rounded, right? It forms an articulation with the acetabulum of the hip bone to form a ball and socket joint called the hip joint or the acetabulo-femoral joint, which is homologous to the shoulder joint. The head of the femur is covered by an articular cartilage, except its central portion, which is formed by a bony depression called the foveae. Here is the foveae. That means all these portions are covered by a cartilage, by an articular cartilage, except this region, this central bony depression. This central bony depression is mainly being a site. It provides a site for attachment of the ligamentum teres. That is what it does, right? So the head covered by an articular cartilage, except this foveae, which gives site of attachment of the ligamentum teres. That is all about the head of the femur or the femoral head. Next is the neck. You can see that the neck connects the head to the shaft. It connects the head to the shaft of the femur, and it is cylindrical. You can see it is cylindrical. It is cylindrical, right? It is directed usually superiorly and medially or superior-medially. Now watch. This is how the bone is being placed. Although this femur is the right femur. It is the right femur, right? It's usually the right femur. So the neck usually directed superiorly and medially, right? Because if you want to determine the position of the femur, you have to understand that the head will be directed medially, right? And the anterior surface is usually smooth. It has to be facing you, right? Alongside with the medial and lateral condyles. That is how to determine the side of the femur or the anatomical side termination of the femur, right? Now, this femoral neck or the neck of the femur usually create an angle that is approximately 135 degrees, which enables the increased movement of the hip joint, right? That is what it does. So it creates an angle that is approximately 135 degrees, which enables the movement of the hip joint. So that is all about the features of this neck. The next feature on this upper proximal end that we shall be discussing is the two bony projection or the two bony processes. First is the greater trochanter. Here is the greater trochanter. This is the greater trochanter. The greater trochanter is the most lateral bony projection that is found on the anterior aspect of the proximal end of the femur. Now, this is the anterior aspect of the proximal end of the femur because here is the anterior surface, right, which goes upward towards its proximal end. So this is the greater trochanter. It is the most lateral. You can see it's lateral because the head of the femur is facing medial. So it is lateral, right? That is why it is the most lateral bony projection that arises from the anterior aspect of the proximal end of the femur. It mostly gives site of attachment of gluteal muscles such as the gluteus medius and the gluteus minimus. It also gives site of attachment of one of quad muscles, that is the vastus lateralis. However, avulsion fracture of the greater trochanter, I repeat, avulsion fracture of the greater trochanter occurs as a result of forceful contraction of the gluteus medius muscle. So that is all about the greater trochanter, right? The next we shall be discussing is the lower or the lesser trochanter, which is here, the lesser trochanter. You can see that the lesser trochanter now is found on the posterior surface because this is the posterior surface. The posterior surface of the femur is usually rough because of the linear aspera. When we come to the shaft of the femur, we'll discuss the surfaces and the borders, right? But for now, let's get the concept. So the lesser trochanter is found on the posterior aspect of the femur. So it is lesser, or I mean, it is smaller compared to the greater trochanter. You can see it. The lesser trochanter is smaller compared to the greater trochanter, right? And it arises from the posteromedial aspect of the upper proximal end of the femur. You can see, first of all, it is on the posterior surface. Why the second thing is that it is medial. You can see it's facing the head, right? It is medial, alongside or just inferior to the head neck of the femur. Why the greater trochanter is lateral from the neck of the femur. Why the lesser trochanter is inferior. It is inferior or below to the head neck of the femur, right? It also gives site of attachment of a muscle, which is called the iliopsoas muscle. It gives site of attachment of iliopsoas muscle. Now, avulsion fracture of the lesser trochanter occurs as a result of the forceful contraction of the iliopsoas muscle. That is all about these two bony projection or the processes, which is being connected by the intertrochanteric crest, right? Now, let's discuss those bony ridges. We have one on the posterior surface of the femur. We have one on the anterior surface. This on the anterior surface that runs obliquely on this aspect is the intertrochanteric line. Why this from the greater trochanter to lesser trochanter is the intertrochanteric crest. Now, the intertrochanteric line is an oblique ridge. It is a ridge that spans between the greater trochanter to the lesser trochanter. It is an oblique ridge or a line, a bony ridge that spans or connect the greater trochanter to the lesser trochanter, right? And as this intertrochanteric line passes downward and pass the lesser trochanter, it changes to be called the pectineal line. This is the pectineal line. Here is the pectineal line. And this pectineal line forms the medial border of the linea aspera. It forms the medial border of the linea aspera. When we get to the shaft of this bone, we shall look into that, right? So, however, this intertrochanteric line provides site of attachment of the strongest ligament of the hip joint, which is called the iliofemoral ligament or the ligament of Bigelow, right? It also gives site of attachment of the capsule of the hip joint. The capsule of the hip joint, right? It provides attachment of the capsule of the hip joint. All these two structures are found on the intertrochanteric line, which is on the anterior surface of the femur, right? While the intertrochanteric crest, which is on this area, is located on the posterior surface of the upper proximal end of the femur, right? It's located on the posterior surface of the upper proximal end of the femur. Now, extending on its superior half, which is here, there is an oblique tubercle, which is called the quadratus tubercle. This quadratus tubercle provides site of attachment of the quadratus femoris muscle, which is here. Look at the tubercle here, the quadratus tubercle. It is a rounded tubercle which provides site of attachment of the quadratus femoris muscle. It is essential that you know all these structures that arises on these bony markings. It is very, very important. It's so much important, right? So that is all about the upper proximal end of the femur. Let's quickly discuss the shaft. Now watch. The shaft is the central portion of this bone and it is the longest portion, right? It extends from its upper proximal end to the lower distal end. Recall that the shaft of this bone is not just straight. When you articulate this femur with the tibia, you will discover that it is not usually straight, right? It's usually medial. This bone, when placed on the body, is not straight on this manner. It's not straight. It has to be medial on this way. That means a kind of being diagonal. It is not that purely vertical. It mediates medially. It is being displaced medially in order to fit in with the central gravity of the body to the knee joint. However, it helps to stabilize the knee joint by being placed slightly medial on this direction. It is not placed purely vertical. It has to be slightly placed medially so that it will maintain the central gravity of the body, thereby assisting the work of the knee joint. The shaft of the femur has surfaces and borders. Here is the anterior surface. The anterior surface is very, very smooth. It is smooth, while the posterior surface is rough because of a linea aspera, right? So this is the anterior surface. This is the posterior surface. This is the medial surface. This is the lateral surface, right? It also have borders. This is the medial border. This is the lateral border. Now, on the posterior aspect of the shaft of the femur, present a longitudinal groove, a longitudinal bony roughened projection, which is called the linea aspera. This linea aspera is a Latin name which means rough line. You can see there's a rough line here. There's a rough line here, a purely rough line on this manner. Look at it here, right? So as this linea aspera, which is a rough bony ridge, descends downward, as it descends downward, it breaks into two or bifurcates into two to form the medial supracondylar line and the lateral supracondylar line. On the center of these two lines lies the flat popliteal surface, which extends downward to form the floor of the popliteal fossa. That is the diamond-shaped depression that is located at the posterior knee, right? Which is the commonest site for popliteal pulse, right? For popliteal pulse assessment. However, as this linea aspera descends upward, that is towards the proximal aspect of this bone, it breaks into two to form the pectineal line and the gluteal tuberosity. This pectineal line forms the medial border of the shaft of the femur, while this gluteal tuberosity forms its lateral border. The gluteal tuberosity provides site of attachment of the gluteus maximus muscle, right? Recall that the greater trochanter provides site of attachment of the gluteus medius and the minimus muscle, right? So that is how it works. Now, let's quickly discuss the lower distal end. The lower distal end. Recall that the medial supracondylar line ends at the adductor tubercle, which provides site of attachment of the adductor magnus muscle, right? Now, what are the features of this lower distal end? It basically have the medial and the lateral epicondyles and the condyles and the intercondylar fossa. Now, let's start from the medial and lateral condyles. The medial and lateral condyle, this is the medial condyle, while this is the lateral condyle. These are rounded bony areas that is located at the distal aspect of the femur, right? They are rounded bony areas. You can see that's located at the distal aspect of the femur. Here is the medial condyle because the head is facing medial, right? While this is the lateral condyle. These two condyles has three surfaces, right? We have the posterior surface, the inferior surface, and the anterior surface. Here is the anterior surface, right? This is anterior surface. This is inferior, while this is posterior, right? Now, the posterior and the inferior surface attaches or articulates with the proximal end of the tibia, while the anterior surface articulates with the patella. Now, two of them, both the patella, this region in which the patella articulate, and these two both region in which the proximal aspect of the tibia articulate, forms the knee joint, right? It forms a knee joint. Now watch, you could deduce that the lateral condyle is larger compared to the medial condyle, right? The lateral condyle is larger compared to the medial condyle, or it is more pronounced or being prominent compared to the medial condyle. Why? Because it protects the natural movement of the patella. It helps to prevent or protect the natural movement of the patella, because had it been is not being prominent compared to the medial condyle, that means there would have been patellar dislocation or patellar displacement, because as the knee is working, undergoing flexion and extension, the patella might displace. But now the lateral condyle is bigger, thereby making patella not to displace laterally. That means it prevents lateral displacement of the patella. So that is why the lateral condyle is more bigger. Now, the next feature we shall be discussing on this distal end is the medial and lateral epicondyle. The medial and lateral epicondyle are the two bony elevation which forms the non-articular part of the medial and lateral condyle. There are two bony what? Elevation which forms the non-articular part of the medial and lateral condyles. Now, you can see that the medial epicondyle is larger compared to the lateral epicondyle, right? So that is how it works. The next feature is the intercondylar fossa. The intercondylar fossa is a bony notch or a bony depression that is found on the posterior surface of the distal end of the femur, right? It's found on the posterior surface of the distal end of the femur. It has two articular facets which provides site of attachment of the intracapsular ligament of the knee joint, which is the anterior and posterior cruciate ligament. Now, its lateral articular facet provides site of attachment of the anterior cruciate ligament, right? So its lateral articular facet provides site of attachment of the anterior cruciate ligament, while the medial articular facet provides site of attachment of the posterior cruciate ligament. That means the lateral part of the medial articular facet provide site of attachment of the posterior cruciate ligament, while the medial part of the lateral articular facet provide site of attachment of the anterior cruciate ligament. That is how it works, right? So I'm being precise on its articular surfaces. Now, when we get to the clinical correlation, you could deduce that there's what we call neck of femur fracture. Neck of femur fracture. They have been divided into two, although the neck of femur fracture occurs as a result of higher energy fall, right? Which leads to the lesion to the capsular region of the femoral head, right? So it is being divided into two. We have the intracapsular fracture and also the extracapsular fracture. The intracapsular fracture occurs as a result of the lesion or the damage to the capsule of the femoral head. And when that is done, there will be a lesion to the blood vessel that supply to the femoral head, which is called the medial circumflex femoral artery. And once that vessel is lesioned or damaged, there will be an avascular necrosis because already there's no more blood supply to the femoral head, right? But when there is extracapsular fracture, there will be no avascular necrosis because there is no relation to the damage of the medial circumflex femoral artery. That is how it works, right? Now, there could be fracture to the shaft of the femur, maybe a spiral fracture, and it mainly been caused by a motor accident, a high traumatic injury, because this bone is a very strong bone, right? So when there is a spiral fracture on this manner, right, it could cause a lesion to the neurovascular bundles of the thigh. There will be a lesion to the femoral artery and also the femoral nerve, right? So that is how it works. The next feature we shall be discussing is ossification. This bone has one primary center of ossification and multiple secondary centers, mainly by 4 secondary centers, right? The primary center occurs in the shaft, where it begins to fuse on the 7th week of IUL. The secondary centers occurs in different regions. It occurs at the greater trochanter, it occurs at the lesser trochanter, it also occurs at the distal end, and it also occurs at the femoral head, right? So those are the ossification centers of this bony structure. I believe we have given a summary on this bone. When you read it on your closet, you could understand it more. Thank you so much for watching. I really appreciate it.